Hey everyone, this lesson is on obstructive sleep apnea. In this lesson, we're going to talk about risk factors for getting this condition. We'll also talk about pathophysiology behind why it occurs. We're then going to talk about signs and symptoms, how it's diagnosed, and how it's treated. So obstructive sleep apnea, or OSA, may also be referred to as obstructive sleep apnea hypopnea. If there are episodes of hypopnea, we're going to talk about what apnea and hypopnea episodes are later on in this lesson. It is a condition involving disrupted breathing or decreased airflow during sleep due to obstruction. This condition is also the most common sleep disordered breathing condition, and it is a very common condition. It is estimated to affect approximately 2 to 9% of the general population, males being affected more than females. And in some instances, the prevalence may be even higher. And due to risk factors we're going to talk about later on in this lesson, the prevalence of this condition is increasing, and it has been increasing over time in the last several decades. And having said all that, even with these very high numbers of affected people, this condition is likely significantly underdiagnosed, meaning that although we mentioned some of these percentages before of patients who are diagnosed with this condition, there are possibly many other patients who are not diagnosed or have been misdiagnosed. So very important to recognize some of the symptoms we're going to talk about later on in this lesson. Now, before we talk about obstructive sleep apnea, it's important to look at the different types of sleep apnea. There are 3 types of sleep apnea. One is known as central sleep apnea. The topic of this lesson is obstructive sleep apnea, and then there is mixed sleep apnea. With central sleep apnea, this is a condition where there are episodes of apnea where there is decreased airflow, but the decreased airflow is due to no respiratory effort that lasts for greater than 10 seconds. So with central sleep apnea, there is no effort on the patient's part to breathe for at least 10 seconds. The reason that central sleep apnea occurs is due to an issue with brain signaling to trigger respiration. So during the day when the patient is awake, the patient can have involuntary and voluntary control of respiration. But when they sleep, it goes to involuntary control. But with central sleep apnea, there is an issue with brain signaling that doesn't trigger the patient to respire or to breathe. Central sleep apnea may be due to an underlying heart disease or brainstem disorder, or it could be idiopathic, meaning that it is primary central sleep apnea, which is a more rare case. Now, the topic of this lesson is obstructive sleep apnea. Obstructive sleep apnea has the same definition of a decrease in airflow for greater than 10 seconds, but it occurs in the presence of breathing effort. Briefly here, the pathophysiology behind why obstructive sleep apnea occurs is because of recurrent upper airway collapse. And more specifically, what this means is that it is due to relaxation or collapse of muscles due to low muscle tone in deep and REM sleep. So again, obstructive sleep apnea is due to relaxation or collapse of muscles and can often include the tongue that leads to the obstruction or blocking of the airway, even though the patient is trying to breathe. We're going to talk about more about this in the next upcoming slides. And then in the third type of sleep apnea, this is known as mixed sleep apnea. And mixed sleep apnea is a combination of both central and obstructive sleep apneas. And what will be noted with mixed sleep apnea is that it may start as central sleep apnea, and then it becomes obstructive as the apnea episode continues. So the patient will start out with a central sleep apnea episode. They have no effort to breathe, but then they will start to try to breathe, but there is obstruction due to some of these reasons we talked about here. So that is mixed sleep apnea. We're not going to talk about central and mixed sleep apnea in this lesson, but if you want more information, please check out my lesson on central sleep apnea. Now let's talk about the risk factors for getting obstructive sleep apnea. One of the most significant risk factors for getting obstructive sleep apnea is obesity. You can imagine that if there is obesity, there can be more tissue around the neck that can lead to obstruction. And this is going to be very important when we talk about some of the lifestyle modification for patients with obstructive sleep apnea. We also mentioned that there is a difference in prevalence between male and female patients. So male gender, or being of the male gender, is a risk factor for getting obstructive sleep apnea. Being older, especially greater than 50 years of age, is also another important risk factor. We can also see family history being a risk factor. We'll mention why that is here in a moment. Patients who are Asian are also at an increased risk for obstructive sleep apnea as well. And then there are particular anatomical features. This ties in with the family history. So some of these include large tonsils, So having very large tonsils in general can reduce the diameter of the airway, making it much easier for the airway to become obstructed. A condition of retrognathia is a condition where the jaw is pushed back or toward the posterior. This again would lead to some issues of decreasing the diameter of the airway, increasing the chances that a patient may have obstructive sleep apnea. And having a large neck circumference, especially greater than 43 centimeters, is also another risk factor as well. The way a patient sleeps is also another risk factor. If they're more likely to sleep supine on their back, flat on their back, they're more likely to have obstructive sleep apnea or episodes of obstructive sleep apnea. Certain genetic conditions like Down syndrome are also other conditions that increase the risk for obstructive sleep apnea. And then alcohol and tobacco consumption are also associated risk factors as well. And then there are some associated medical conditions as well. These may be risk factors, but they may also be consequences of obstructive sleep apnea, which we're going to talk about later on in this lesson. Some of these include stroke, hypothyroidism or low thyroid functioning, and metabolic syndrome. Now let's discuss what happens in obstructive sleep apnea. During sleep, there's going to be a decreased muscle tone. And in particular, the lowest muscle tone is going to occur during REM sleep, so rapid eye movement sleep, when patients dream. This is when they're going to have the lowest muscle tone, and this is when they're going to have the most episodes of obstructive sleep apnea. So what's going to happen is muscles like the tongue and some other structures in the neck may relax too much, leading to a blocking of the airway. And you can imagine that if you have this blocking, you're not able to get air through that obstruction. That's going to lead to episodes of apnea. Apnea, more specifically, are again those episodes of decreased airflow for greater than 10 seconds. In obstructive sleep apnea, it is in the presence of respiratory effort. But more specifically, the definition of apnea is when there is greater than 90% anterior to posterior collapse of the airway, meaning that there is greater than 90% of the collapse of the airway from the anterior to the posterior. This is the anterior here, this is the anterior of the patient, and this is the posterior of the patient. When the patient is lying flat or in the supine position, this is where it's going to be most likely to occur in the patient. And again, an episode of apnea is where there is greater than 90% anterior to posterior collapse of the airway for greater than 10 seconds. And the reason why I put so much emphasis on the exact definition of apnea is because there is also something known as hypopnea. We talked about this before when we talked about the fact that obstructive sleep apnea can also be referred to as obstructive sleep apnea hypopnea, because there may also be episodes of hypopnea as well. Hypopnea are like mild versions of apnea episodes, meaning that there is reduced airflow and it's greater than 10 seconds and there is still respiratory effort in obstructive sleep apnea, but it isn't as severe of a collapse of the airway as in apnea. In hypopnea, it is greater than 30% anterior to posterior collapse of the airway. This is going to be a characteristic of hypopnea. And both episodes of apnea and hypopnea can lead to decreased oxygenation levels as well. So episodes of hypopnea are very important to recognize as well, because they can also lead to decreased oxygenation levels for the patient. Now let's talk about clinical features of obstructive sleep apnea. So as we have talked about previously, we're going to see episodes of apnea, and we're also going to see episodes of hypopnea, but we're going to more specifically focus on the episodes of apnea here. So apnea is again a cessation of breathing or airflow. In the case of apnea, it is where there is greater than 90% anterior to posterior airway collapse. So it's a significant decrease in airflow. And again, the episode of apnea occurs in the presence of respiratory effort. So the patient is trying to breathe, but they're not able to get air or airflow past the obstruction. These episodes can occur many, many times during the night. It may occur hundreds of times per night, and we're going to see it most commonly in rapid eye movement sleep or REM sleep for reasons we mentioned before. And these episodes of apnea can be witnessed, and this is going to be important when bringing this up to a clinician for further assessment, because oftentimes the patient may not know they are having episodes of apnea. It's oftentimes going to be their significant other that has witnessed the apnea episode that's going to bring attention to it. So this is going to be important when assessing whether or not a patient has obstructive sleep apnea. Has it been witnessed? Another important clinical feature of obstructive sleep apnea is snoring. So this snoring is going to be very loud, chronic, and bothersome to others. So again, this is going to come back down to have others witnessed them snoring and having episodes of apnea. Now, snoring is very common. It's more common in prevalence than obstructive sleep apnea. And not all patients who snore have obstructive sleep apnea, but it's important to look out for. And what's going to be very important with the snoring is that the snoring can become disrupted or stopped during apneas, followed by a snort. They'll often make a snort or a gasp or a choking sound. So this can be very, very important to recognize. And this is going to be very key in recognizing, because if a patient has this, if they often have snoring and it becomes very disrupted and they have a snort or a gasp or a choking sound, this is going to be very, very characteristic and increase the likelihood that that patient has obstructive sleep apnea. They can also have repeated nighttime arousals and awakenings because of their episodes of apnea and their snoring. They can have insomnia as well, so they can have difficulty sleeping. They can have early morning awakenings where they're not able to go back to sleep because of these episodes of apnea and the snoring we talked about before. So they can have a lot of tossing and turning. The gasping we talked about before is very important to recognize. Remember that that may be associated with the snoring as well. And then they can have nocturia as well, which is increased urination during nighttime. So it's nocturnal urination. Nocturia can occur in patients with OSA as well. Now, there are some other findings that are important to recognize. Obstructive sleep apnea patients are oftentimes going to have a headache in the morning. This can be due to the snoring and due to decreased or issues breathing. They can have morning confusion. They can have a dry or sore throat. And what's going to be very significant and detrimental to the patient is going to be daytime somnolence. So they're going to feel very, very tired throughout the day. If they are very, very tired throughout the day due to obstructive sleep apnea, it's often termed as obstructive sleep apnea hypopnea syndrome or simply obstructive sleep apnea syndrome. We can also see fatigue being a very common finding. Patients often will have decreased ability to concentrate and difficulty with memory as well. And then to tie it all together, the 3 S's are a way to help remember the very key components of obstructive sleep apnea. And these include snoring, sleepiness, so that would be the fatigue and the daytime somnolence. And the third S is significant other observes the apnea episode. So these 3 S's are going to be very important to help remember the very key characteristics of obstructive sleep apnea. So those are the signs and symptoms of obstructive sleep apnea. But having obstructive sleep apnea not only causes those signs and symptoms, but it also increases the risk of other medical conditions and causes other medical conditions as well. The reason it does that is by the following mechanism. So this is going to be another slide on pathophysiology behind what happens in obstructive sleep apnea to cause some of those health conditions we're going to talk about here in a moment. So we mentioned that obstructive sleep apnea causes arousals, and because obstructive sleep apnea leads to episodes of apnea and hypopnea, it leads to decreased airflow, leading to decreased oxygen levels or oxygen desaturation, and can also lead to hypercapnia or increased CO2 levels. And it also leads to decreased intrathoracic pressures as well. These 3 effects are going to lead to downstream consequences. So with arousals, because a patient becomes awakened by their snoring or their episodes of apnea or hypopneas, they're going to have increased catecholamine levels. And those increased catecholamines, which are epinephrine and norepinephrine, they're going to lead to increased blood pressure and increased heart rate. With regards to the oxygen desaturation in the hypercapnia, it's going to lead to decreased myocardial oxygen or O2 delivery. And it's also going to lead to oxidative stress and inflammation. And the decreased intrathoracic pressure may lead to increased left ventricular wall tension and increased cardiac O2 or oxygen demand. So with all of these, obstructive sleep apnea can increase the risk or cause the following conditions: hypertension or high blood pressure, cardiovascular disease, left ventricular hypertrophy. There is some question as to whether obstructive sleep apnea increases the risk of heart failure. Obstructive sleep apnea can also lead to arrhythmias and also increase the risk for stroke. So because of these mechanisms we mentioned here, all of these conditions are more likely to occur in a patient with obstructive sleep apnea. So that leads us into the health complications. Again, we mentioned that hypertension is one health complication, so that is a high blood pressure. One that we didn't mention is that obstructive sleep apnea is associated with gastroesophageal reflux disease, and this may be related to the risk factor of obesity. Obstructive sleep apnea can lead to cardiac arrhythmias as well. It can also lead to or increase the risk of coronary artery disease, and there is again a question of whether this increases the risk for heart failure as well. And another very important health complication I didn't mention in the last slide was pulmonary hypertension. So obstructive sleep apnea has also been associated with an increased risk of pulmonary hypertension. Stroke is also another health complication of obstructive sleep apnea. So OSA has been found to be associated with increased risk of stroke. There's also increased risk of depression and anxiety in patients with obstructive sleep apnea. There's also issues with sexual dysfunction, and there's also an association with metabolic syndrome as well. So this association with metabolic syndrome is interesting. As we mentioned before, obesity is an important risk factor for obstructive sleep apnea. So patients with obesity are more likely to also have metabolic syndrome, but obstructive sleep apnea may increase the risk of or lead to metabolic syndrome itself. And the reason that this may be the case is that there have been findings that having obstructive sleep apnea increases insulin resistance and decreases glucose tolerance. So that's going to be important in the pathophysiology in metabolic syndrome. So that's going to be important to make note of here as well. How do clinicians diagnose obstructive sleep apnea? A clinical examination is going to be important. We mentioned that there are often going to be health effects from the obstructive sleep apnea itself, but also potential risk factors for getting sleep apnea. So a clinical examination is going to be important. Blood tests are oftentimes not going to be required, but they can be important when the question is whether or not there is an association with hypothyroidism. As we mentioned before, hypothyroidism is an associated condition with obstructive sleep apnea. So doing a blood test, checking thyroid stimulating hormone levels and T3, T4 if appropriate, if again, thyroid disease is suspected. But what's going to be required for the diagnosis of obstructive sleep apnea is a polysomnography. So polysomnography is a sleep study. So a patient will sleep in a sleep clinic or a sleep lab. So this is where the patient's going to have their respiration monitored, they're going to have their muscle movements monitored, and some other things monitored as well. And they're going to have a readout of their airflow and some of their respiratory efforts measured. And in obstructive sleep apnea, as we mentioned before, there's going to be a cessation or a very significant reduction in airflow for at least 10 seconds, but in the presence of persistent respiratory effort. However, in central sleep apnea is where it is a cessation of airflow for at least 10 seconds, but without respiratory effort. So these are going to be potential findings in a polysomnography readout. So again, polysomnography is required for diagnosis. And again, this is an overnight sleep study. There are some other measurements that can be utilized in a polysomnography, and one of them is going to be an apnea-hypopnea index, or AHI. An apnea-hypopnea index is the number of apneas and hypopneas divided by sleep time. And oftentimes the cutoff or the threshold for AHI in a particular sleep study is going to be roughly 5 to 10 per hour. So 5 to 10 apneas and hypopneas per hour. But the cutoff and the threshold and the measurements as to the severity are going to differ between different sleep clinics or different sleep labs. But as an example, some of the numbers that may be utilized include 5 to 15 per hour for mild obstructive sleep apnea, 15 to 30 for moderate sleep apnea, and greater than 30 per hour for severe sleep apnea. So those are some of potential numbers that may be used for determining the severity of obstructive sleep apnea. But again, these numbers could differ between different regions and different sleep laboratories. And then imaging may be utilized in some cases, especially when trying to identify the site of obstruction. So some imaging modalities may be used in certain circumstances to identify the site of obstruction. Now that we know how obstructive sleep apnea is diagnosed, how do clinicians treat it? So oftentimes, lifestyle modification is going to be employed. So lifestyle modification is going to be non-invasive modifications in a patient's life. One of them is going to include weight loss. As we mentioned before, obesity is going to be an important risk factor for getting obstructive sleep apnea. Alcohol avoidance is also important, especially 4 to 6 hours prior to bedtime. Something known as positional therapy, which just means sleeping on your side instead of sleeping supine or sleeping lying flat, is going to help reduce some of those episodes of apnea and hypopnea. Again, because with the influence of gravity, we're going to see more anterior to posterior airway collapse or too much relaxation from the tongue and some other associated tissue that could block the airway. So those are some of the lifestyle modifications that can be employed. But what's going to be very key with treating obstructive sleep apnea is nasal continuous positive airway pressure, or nasal CPAP. So nasal CPAP is going to be this machine here. So it's that machine that's hooked on at night that provides the patient airflow and helps prevent airway collapse to prevent hypopneas and apneas from occurring. Nasal CPAP is going to lead to significant improvement in symptoms and will often lead to significant improvement in excessive daytime sleepiness. But it's important to have daily adherence, as daily adherence is often going to lead to complete or near complete resolution of symptoms. In some cases, instead of a CPAP, a bi-level positive airway pressure or BiPAP may be alternatively used as well. Now, nasal CPAP is going to be the first line treatment. We mentioned that obstructive sleep apnea leads to many different signs and symptoms, but most importantly, it increases the risk for very detrimental health conditions as a patient continues to have obstructive sleep apnea. So it's going to be important to treat it. So nasal CPAP is going to be the mainstay of treatment here. In the case where a patient doesn't have improvement with nasal CPAP or they don't want to use the nasal CPAP machine, they can often use oral appliance therapy. But again, nasal CPAP is going to be the mainstay of treatment. And then in some cases, if there is some anatomical issue like enlarged tonsils, certain corrective surgeries may also be employed, such as tonsillectomy, so removal of the tonsils. So those are something else that could be used if there is some anatomical issue that is leading to the obstruction. If you want to learn more about central sleep apnea, please check out my full lesson on that topic. And if you haven't already, please like and subscribe for more lessons like this one. Thank you so much for watching and hope to see you next time.